I'd like to bring to your attention the paper that's just come out based on the National Stroke Audit, which has come in with some really interesting findings relevant to the debate to do with 7-day working, but actually adding a huge amount extra to this discussion. So this is an audit commissioned by HQIP and performed by the Royal College of Physicians. But what this paper is based on, it's based on the data that the audit has provided. The hypothesis tested was, is care quality dependent on day, but also time of admission? So a really kind of in-depth look, not just weekend versus day, but also the actual days. And the days indeed split into aliquots of 4 hours. So a really insightful review coming out from the stroke audit data. So it's based on actual data that's been collected, and the data was collected prospectively. And it's a huge data set. It's based on something like 74,000 episodes through 199 hospitals. And it has added greatly to this discussion about quality of care based on day. I'll just go through the standards that have been used, and they're really important standards, obviously based a lot on the NICE standards, and they are as follows, and I'll go through these because it really is important that when you read this paper you understand that it's not just pick one or the other, it is actually the real markers of quality when dealing with stroke. So it's things like the time-critical nature of acute stroke care, and I'll come back to that later because there are many other areas in healthcare where there are time-critical areas, and this has shown how using the audit we can look at that. So obviously there's things like brain scanning, the times to brain scanning and to do with admission and the like. Very important things that we all know about: direct admissions to a stroke unit within certain times, administration of intravenous thrombolysis, and again times there, the dysphagia screen, reviews by stroke specialists, that both physicians and nurses, assessments by physiotherapists, occupational therapists, speech therapists, etc. within times. And the other very important thing obviously is to do with outcomes in terms of 30-day. So we have these very important standards. And so what have they found by doing this in-depth analysis? And they've come through with some really interesting findings showing that to look at this in a simplistic way, that is day of the week versus weekend, is inappropriate. But there are these important variations, and they've classified them in 4 ways. One is diurnal variation. Things like, I'm not going to go through the paper, obviously it's really important that colleagues do go in and read this, but just to give you a feel for it, dysphagia screening, for instance, times to brain scan, there were very diurnal variations seen in that. Day of the week pattern, definitely important there. So interestingly, what they assessed was there was less good care at the weekend, but in addition, also on Thursdays and Fridays, which is very interesting. And then there was an out of hours pattern, as they termed it. So somewhat less good out of hours care at the weekends, and that particularly applied to thrombolysis. And then finally, there was a flow pattern seen in terms of qualities of care, and that is, as they classified it, sequential change in quality by day and time. So the quality increased during the week and then fell off the weekend. And interestingly, there were other findings, but for instance, admission to a stroke unit, the least number of patients being admitted to a stroke unit was on a Monday, in fact. So this gives you a feel for the findings, which obviously adds to the debate about quality by day, but shows you when to just say weekend versus weekday, it's far too simplistic. There's a lot more information coming from this audit, adding to this debate. So what will we do with it? Obviously, we'll take this back, the authors and the colleagues in the stroke services, back out to clinicians, to managers, to commissioners, to show that there would be ways of using this really high quality information to improve our services. We're really interested in this paper because it's shown us, in addition to the clinical community, that the power of our national audits, in particular stroke obviously is one of our really good audits, but what we would hope to do is to work with colleagues, Royal College of Physicians, but others as well, into using this methodology. Indeed, the authors of the paper themselves have said, and I think I mentioned this already, that looking with this methodology at other time-critical illnesses or processes of care, they've suggested myocardial infarction. And indeed, I know colleagues in the primary angioplasty world have done work on looking at the time-critical nature and the quality to do with angioplasty, although that was on one particular area, which was to do with access to primary angioplasty. But there are lots of other areas. For instance, obstetrics is one that springs to mind, which is really time-critical. And the more one thinks, the more with this, the breadth of the audits extending, you know, the HQIP audits extending through about 40 areas, and then many others that we work with colleagues on, covering a huge variety of healthcare, that using this methodology and kind of thinking in this kind of way is, how can we use this information? Like, the information is there, can we analyze it differently? Can we break it down differently? And I think that's the really important part of this paper. When you actually drill back down, not the research paper, but to the audit itself, and as I mentioned earlier, it's based on findings from 199 hospitals. Each of those hospitals will be getting its own report based on the findings of the audit in the year preceding. And so each one of those hospitals will be able to take their results coming out from the stroke audit and shape themselves up against the findings coming out from this paper. And that will be a real improvement tool in terms of how can I, that is a stroke physician and a stroke nurse, the manager in the hospital, the commissioner of the service, and that, how can we work together looking at the service that we are actually providing, that we know that we're providing based on the audit findings for us, matched up against these findings, which give this really, really in-depth analysis, and how can we match ourselves up to that analysis, and how can we make our service better for the cohorts of patients coming in with stroke. And I think that's another really powerful part of this paper. So it really breaks down into these 4-hour areas and you know, day, night, weekend, days of the week. How can we actually work with our therapists, for instance, to say, you know, this audit looks like it's showing this. In our service, we're probably doing this. How can we actually make it much better for all of our patients coming in so that we address these issues, the temporal issues coming out from the audit?